Manoj, Purvi, as well as Bansi. So basically, this is one interesting slide of a cardiologist, or you can say physician cardiologist, Dr. Kraft, who was practicing in 80s, and he used to practice preventive cardiology, and he used to do those who are in diabetes, you might be knowing Kraft test. So he was one who used to study postprandial insulin rise and postprandial dysglycemia, and his statement is, I think, is what today my talk is. He used to say those with cardiovascular disease and you cannot identify diabetes, they are simply underdiagnosed. What did Kraft showed more than 3 to 4 decades back? That my patient who is a cardiac patient, even if he's not diabetes, so I am missing and probably it is a insulin resistance. And now what I can see, the medications which for diabetes is showing a significant reduction in cardiovascular events. So I think he was quite a good visionary. Now for these medications or glucagon GLP-1 analogs, they have gone through a long journey from 2005 to now 2000. So 2 decades of a clinical experience, and like SGLT2 inhibitor, they came as a diabetes medicine. And now SGLT2 inhibitor is a very standard drug, and interval MI ejection fraction 30%, no diabetes, I am prescribing. So they travel from a non-diabetic drug to a diabetic drug to a now cardiology drug. Similar journey is with GLP-1 analog, but the GLP-1 analog is not like simple like a SGLT2 inhibitor where you have only one dose. It is a nephroprotective, it's a cardioprotective, it is a anti-diabetic agent. Here you have a dose variation. These drugs in lower doses are anti-diabetic, but if you go in high doses, then they become an anti-obesity drug. And even today what I am presenting is a select study which is a higher dose in non-diabetic. So this was the first in 2006. You can see up is the indication for diabetes, lower is an indication for obesity. It is the same drug. Liraglutide, when it is in lower dose, you call it Victoza, and it is a diabetic drug. Saxenda, when it is higher dose, it is an obesity drug. So molecule is same, but they keep a different name. So this is first time in medicine or cardiology I have across that lower dose is different name and higher dose is a different name, and sometime it would cause some confusion among us. In 2016, the liraglutide came with an CVOT or cardiovascular outcome trial, and it showed it can reduce the major adverse cardiovascular event by 13%, and it was the first drug which reduced the mortality, and it came in the cardiology picture that if a patient is diabetic and he has an MI, you can have benefit which is multifold, which includes reduction or secondary prevention of MI, benefit as good as statin. It's an anti-diabetic drug also, and helping in weight reduction and the reduction in other cardiovascular risk factor. And from there we have another CVOT with semaglutide. Again, if you can see semaglutide 2019, oral ribelsis came in 2019. In 2016, this is another publication called Sustain 6, another CVOT from semaglutide, which showed the similar reduction in MACE events. And this journey goes to a higher doses where this molecule is now an obesity drug, and we know in 21 we got an approval for an obesity indication, and you have seen Dr. Bhartiya has told you about those step trials. So with this background, this is CVD. CVD in India is a growing burden, and this is coupled with obesity. What you can see is the ICMR India study projection that 254 million adults India would have generalized obesity and 350 million and abdominal obesity. We have seen reduction in the cardiovascular mortality with improving care, oral medications, cardiac interventions like angioplasties and surgery. However, what we have seen, obesity related cardiovascular events are increasing. And this is one of a study from UK, a retrospective analysis that cardiovascular disease and obesity are linked, and you have a hazard ratio of 1.2 for coronary, 1.2 to 1.4 in CVD. Similar you see with cerebrovascular disease also. However, those patients with obesity who are metabolically good, no dysglycemia and all, still they have 38% increase risk of CVD and 65% increase in heart failure. If this metabolically unhealthy, healthy obese become metabolically unhealthy, then they biochemically they start becoming abnormal, then this risk increases or doubles. Though we know weight loss would reduce the cardiovascular risk factor. Since 2 decades in my clinic, I am always telling my cardiac patients after their procedure that you should need to reduce weight so that your sugar will be better, your cholesterol will be better, your blood pressure will be better, and that would be helping to reduce your future risk. But we know, as you have seen in the last presentation, it is difficult. Moment you are withdrawing these drugs, even with drugs, if you maintain weight loss, withdrawal has consequences. So maintaining and achieving weight loss was a tough task. And there are many pharmacotherapies which have been tried. Everybody knows of these drugs and they have been tried whether they can reduce in obesity, but the CV event had either they are increased or they are not or neutral. So none of the pharmacotherapies which include sibutramine, rimonabant, naproxen, bupropion, none of them could show a reduction or reduction in cardiovascular events. And with this background, this is a select trial. How select trial is a next big bold step from Novo Nordisk, where they have selected patients with obesity. Now by this time you all know in diabetes we have Sustain 6 which shows it reduce MACE, but it is in a diabetic population. What Dr. Bhartia showed you was the recent STEP trial where you can target obesity, and these are all non-diabetic patients. Now what select is much larger study, a longer duration over 40 months, and you have seen one slide in Dr. Bhartia telling that long and sustained 5-year data from this. So this is a large trial. It includes obese or overweight patient, but they are not diabetic and they have already an established cardiovascular disease. So what we are going to prove, what John Kraft told, that there is no diabetes and patient has cardiovascular risk, and this anti-diabetic drug, can it reduce the cardiovascular event? So this is a select trial design which is basically overweight obese patients. They already have ASCVD, 70% have coronary artery disease, 24 had a stroke, 4 to 5 had up even only peripheral vascular disease. So these type of patients who are not diabetic, means their HbA1c is less than 6.5 and they are obese cardiac patients, and this is definitely a placebo versus semaglutide. So patients are on a standard of care for the cardiovascular disease, which is what we call secondary prevention, and these are the primary endpoints, which is cardiovascular death, non-fatal MI and stroke, what we call MACE event, and there are confirmatory secondary endpoints. These secondary endpoints is occurrence of CV death, composite heart failure endpoints, as well as all-cause death. So you have CV death, all-cause death and heart failure endpoints. So you can see this is a population, 70% male, mean age is 60. All races are including Asians, which is 8.2%. As I told, 70% are coronary artery disease, 20% are stroke, 4% are only PAD, and 8.2% have more or two vascular beds which are involved. They are on a standard of care. Standard of care is treating their lipid, blood pressure, antiplatelet, because all have ASCVD, and glycemic control, because see, please understand, there are no diabetic patients here, but yes, during a course of a trial, if they develop diabetes, then diabetes is treated as per the standard medication, and they have being for healthy lifestyle, which includes physical activity, smoking and alcohol cessation. And on the right side, this is the protocol of the hypertension treatment. They are very appropriately treated. Their blood pressure was average 130, and both arms had a good lipid lowering. And you can see this distribution of the drugs, as these all are cardiac patients. They are on ACE ARBs, they have hypertension, they are on antiplatelet, lipid lowering. So at the end, what we see at 40 months, you can see this Kaplan-Meier trial, where Kaplan-Meier curve which shows 20% reduction in the MACE event, which is statistically significant. Again, the most important thing here is these are all non-diabetic patients, but yes, they are obese. So semaglutide had been now ESC recommendation as an obesity medication in patients with chronic coronary syndrome to reduce CV mortality, MI and the stroke. Similar is what we will call in an Indian label now. with the Wegovy. And the most important thing, then there are multiple analyses. There are almost 20 paper coming out with subgroup analysis and different what is driving here. So what has been seen that the maximum weight loss, the curve start driving very early. You can see as early as 6 months, but the peak MACE events, the weight loss is only 5%. So the message is, it is not only the weight loss or obesity treatment which is giving an benefit. These drugs have a specific anti-inflammatory action, a plaque stabilization action, and multiple effects directly on a cardiomyocyte, endothelial cell, as well as the smooth muscle cells of the vascular media. So these MACE curves separate much before the weight reduction. These the statistical analysis shows that this 80% of MACE reduction with Wegovy is mediated by other factors apart from weight loss, and MACE reduction definitely is independent of these body weight changes. So secondary endpoints, if you see the first confirmatory 8 point of cardiovascular death, it is not statistically significant, but it is 15% reduction. Apart from that, 18% reduction in the composite heart failure point and a 19% reduction in all cause death. So all sub analysis, if you go and see, all GLP-1 analog have shown reduction in a MACE, but you might find some differences. For example, when we see leader trial, it is predominantly a cardiovascular death reduction. If you see sustain 6, it is predominantly a stroke reduction. Here you can see balance, but probably the non-fatal MI and coronary revascularization are little more than all other what we say is measured cardiovascular outcome. So these are the various ways by which in select trial these are other benefits, which is reduction in inflammatory marker of hsCRP, lipid, and HbA1c reduction of 0.3, blood pressure reduction, waist circumference going by 6.5 centimeter, and a weight reduction of 11.1%. What you can see, this pre-diabetic population was almost 2/3, 60 to 70%, and as you know, this is the first to start with our anti-diabetic drug. And in this active arm, where there were 68% patients with pre-diabetic, they went into a normoglycemia, which means HbA1c less than 5.7, which is an expected outcome as a pre-diabetic population moving to a HbA1c less than 5. So one of the largest CVOT of a diverse population all over the world, more than 100 centers, 40 months long trial, it has shown a reduction in MACE by 20%, and this benefit is irrespective of weight, because you know 30% a small population, BMI between 27 to 30, which we call overweight, irrespective of their glycemic status and age. So this is how SELECT is one of a trial which has changed our clinical practice as an anti-atherosclerotic drug. So despite standard of care, CV events remain high in these patients with obesity, and definitely there is an unmet need, and guidelines have approved this 20% MACE reduction. So last 5 acute MI patients in which I have done an emergency or an angioplasties, out of them 4 fit into what we call is SELECT. They are 45 to 55. They don't have diabetes, they are not smoker, their lipids are okay, but still they had a coronary event. The 5th one is a diabetic. So out of last 5 patients they are. So we are seeing this changing pattern of disease, and definitely this was an unmet need. Thank you.
Thank you, Dr. Kahale. And
so this is now obesity as a new modifiable risk factor apart from these what we are treating as a cardiologist. Thank you.
thank you.